Okay, hi, thanks for having me. I'm Matt Smith. I'm a neurologist at the University of Cincinnati. I work in the neuroscience intensive care unit, which is where I'm at today on this beautiful Saturday morning. And I specialize in taking care of people with severe brain injuries who require ICU level of care. I'm also undergoing additional training with Dr. Shirani Grossman and Presta Giacomo on the endovascular treatment of aneurysms, strokes, vascular malformations, and other cerebral vascular diseases. Disclosure I have today, I'm going to be talking about headache treatment for persistent headaches following a subarachnoid hemorrhage and aneurysm rupture, and there are currently no FDA-approved treatments for this disease. All medications and devices I'm going to talk about are off-label, and that's part of the problem. What I'll talk about is that there's no approved treatment for this problem. I always talk to patients about the 5 stages of a subarachnoid hemorrhage. The first stage rupture is, unfortunately, you're typically on your own. It has to be recognized. You have to get to the hospital. A neurosurgeon may have to place a drain to help you deal with the swelling in the brain, the hydrocephalus. After that, the aneurysm needs to be repaired. There's then a typically 7 to 21-day ICU stay to monitor for vasospasm. And after that, we get to enter the recovery phase. As a neurologist, a neurointerventionalist, and a neurocritical care doctor, I get to take care of people in the angiography suite, where we repair their aneurysm, in the ICU, while they are getting their vasospasm treatment and doing the immediate recovery from the rupture, and then in the neurology clinic as well, where I help manage some of the cognitive problems and some of the recovery problems that are seen after a brain injury. So what I'm going to talk today is a persistent headache after an aneurysm rupture, and I define this as a headache lasting greater than 3 months from the rupture. The typical spiel people get is you have a bad headache now, but it'll get better, and it turns out that's not necessarily true. About 40% of all subarachnoid hemorrhage survivors have continued headaches, even 3 months and greater after their rupture. Most rank the scale between a 3 and a 5 out of 10 on a daily basis, with spikes getting higher, up to several times a day, or if you're lucky, only a couple times a week. But it's a problem, and it can be debilitating. Patients who have a persistent headache after aneurysm rupture, when they fill out scales ranking their quality of life, they score lower than patients without a headache. They talk about having less functional independence, and because of the headache, an inability to tolerate rehabilitation, to go to the rehab, to do the training, to get on the rehab bike, get on the treadmill. It can be a real debilitating issue. Unfortunately, there is no diagnosis for a persistent headache after aneurysm rupture. This is a snapshot of my electronic medical record. And as you can see, if you go and see your doctor for any number of problems after an aneurysm rupture, a cognitive deficit, language problems, swallowing problems, weakness, they can type in and bill correctly and label your problem. But if you go to your doctor after a subarachnoid hemorrhage and I say, I still have a headache, there's actually not a ICD-10 coded diagnosis for that. So what happens is we put it in your chart as a post-traumatic headache, or a chronic daily headache, or a migraine, or some other diagnosis that doesn't really describe what you as a patient are going through. The International Classification of Headache Disorders, they do have a diagnosis, persistent headache attributed to past non-traumatic subarachnoid hemorrhage. So this is not a billing or a medical diagnosis, this is a classification. And if you go to their website and click on their link, you get this very helpful page. That is exactly what's on the page. They haven't built it out, and instead they link you to just this general headache attributed to a non-traumatic hemorrhage, which subarachnoid hemorrhage is a different entity from other hemorrhages. So even headache classification disorders do not really do a good job of describing what this is. So none of these treatments are FDA approved for a persistent headache following a subarachnoid hemorrhage because it is not recognized as a disease. There's nothing to approve it for. The first step I will take, though, is just over-the-counter medications, acetaminophen, NSAIDs like ibuprofen and naproxen. I will not use NSAIDs in the acute period following a subarachnoid hemorrhage because they can cause increased bleeding. but weeks to months following an aneurysm repair, they are safe. But I do tell people to limit this to no more than 3 times a week. And the reason is, with repeated use of these medications, you build a tolerance and you can have a rebound headache, which makes your headaches worse and worse and worse and worse. The next step I will often try is an anti-epileptic medication or a seizure medication. Valproic acid is good at controlling headaches. It has side effects of weight gain, though. It has cannot be used by people who are trying to get pregnant. Gabapentin is very effective at controlling headaches, but you have to take it 3 times a day. It can make you sleepy. It can make you feel numb. And topiramate is very effective at controlling headaches. It can be taken once a day at night, but it can cause kidney stones, hair life, and most people find themselves thinking slower, having cognitive issues, all things that you don't want to deal with while you're recovering from your brain aneurysm. Some antidepressants can help with headaches. Tricyclic antidepressants like amitriptyline, nortriptyline, dazipramine are very effective headache medications. You take it once at night when you go to bed. They can cause weight gain, they can cause dry mouth, they can cause GI upset, and they can cause fatigue even the next morning when you wake up. The serotonin, norepinephrine reuptake inhibitors like venlafaxine and duloxetine have a much lower side effect profile. The most common side effect is some nausea, but they're just not as strong at controlling headaches as the other medications. So often, while trying one of these medications, I will prescribe an adjunctive therapy as well. One of my favorite therapies is acupuncture. Most insurances will pay for acupuncture. This is a paper from the Neurocritical Care Journal, and it has recommendations of trigger points. So for people with traumatic brain injury or a headache after an aneurysm, I've printed them out treatment points and send them to an acupuncturist. And some people, not everyone, but some people do get relief out of this. It's very low risk and it's typically covered by insurance. I'll also use non-invasive neurostimulation in the treatment of headaches. The mechanism can sound a little far-fetched. You use a low-grade electrical current to stimulate either the vagus nerve, which is down here, or a supraorbital nerve. This provides a feedback mechanism which can desensitize the dura, which is the layer that surrounds your brain and is responsible for pain. Supraorbital stimulation is a small device that's placed on the forehead for up to 20 minutes a day. And with continued use, it can help desensitize the dura and decrease frequent headaches. It's well tolerated. Insurance is typically pay for it. If not, you can usually purchase it on your own for about $250 with a prescription. This is a model using one. Here's a much less flattering photo of me trying one out as a resident. The shocked look is because it is a little uncomfortable the first time you use it. We kept one in our residency office and we would all take turns using it, and it's an electrical current, so you feel warmth and a little buzzing on your forehead, and it's a little bit of a shock. It's well tolerated, but some people don't care for it and move on to try other devices. Vagus nerve stimulation is a newer technique. I have not prescribed this device, but there is a randomized controlled trial going on in North Shore University in New York, the Vanquish trial, where they're actually using this device to try and treat persistent headache after subarachnoid hemorrhage. Very excited to see when it comes out. There's the clinical trials identifier down there. If somebody has migrainous type headaches following a subarachnoid hemorrhage, and a typical migraine would be unilateral throbbing pain, blurred vision, nausea, vomiting, fatigue, needing to go lay down in a dark room. If the headaches are specifically migrainous, we can use botulinum toxin injections. This is very hard to get insurance to pay for. It is prohibitively expensive for out of pocket. So the headaches must be migrainous in nature. And this is every 3 months you come in and you get a series of small Botox injections around the forehead. It's very well tolerated. It's a tiny pinprick, few here, dots on the side of the head and a few dots in the back. And it tends to do pretty good migraine control. And then the newest therapy available, and this has to be for migraine headaches, is AntiCGRP injections. This is an injection not in your scalp, but you do it into your leg once a month. It's CGRP is an immunomodulatory molecule that causes dilation of the blood vessels and can lead to increased pain in the head, can do some of the nausea, the insensitivity to light. So by blocking that, it can help with some of those symptoms. It is only indicated for migraine type headaches. I would not prescribe this medication to somebody who has just ruptured an aneurysm because we worry about narrowing of the blood vessels, and this medication prevents dilation. So although there's no reason to think that this medication would cause vasospasm, I would only prescribe this medication to somebody who months to a year after their aneurysm rupture was having migraine type headaches, and I would do it in conjunction with their treating neurosurgeon, neurologist, or neurointerventionalist. I have used this medication in a couple patients who remotely had aneurysm ruptures years and years ago and have had intractable migraine since then, who then using this medication were able to get some control and some of their life back. Again, all of these are not FDA approved for this indication. So what are the next steps? I think the most important thing that can be done from a patient advocacy group is to make sure that we actually get a diagnostic code developed for a headache following subarachnoid hemorrhage or persistent headache following a subarachnoid hemorrhage. If you can see the bottom of my screen here, there are 250 diagnoses related to a subarachnoid hemorrhage, and none of the ICD-10 codes, at least in my healthcare system, have to do with a headache. And so that's a great place to start for advocacy. The more we label something, the more we code it, the easier it is to study, the easier it is to develop treatments. And I'll see if anyone has questions.
Thank you, Dr. Smith. We do have a question, and it is it possible for an SAH patient, a subarachnoid hemorrhage patient, to start getting headaches for the first time years after the bleed?
Yes, so headaches are common. What I would do in that case, I would talk to a neurologist if you're having headaches, and a neurologist can help you figure out what types of headaches they are. Are they tension headaches? Are they migraine headaches? Are they cluster headaches? All of those types of headaches, even though they're distinct entities, they can still be provoked by a remote brain injury. In fact, when I see a patient for new headaches, I always ask, have you had a brain injury? Have you been in a car accident? Have you had a bleed in your head? And once we kind of classify what type of headache you're having, treatment can be tailored appropriately.
Sounds good. Let's see, I think we might have one more question here too. Is it possible the headache will last 10 years?
Unfortunately, yes. And that is, I mentioned using the anti-CGRP inhibitors. That patient, one of the patients I treated with that was at the VA hospital who had been having migraines for more than a decade after their aneurysm rupture. And they were distinctly migrainous type headaches, and we were able to get some control with that medication. But yes, it's a chronic, it is a debilitating problem, and it is under-recognized.